So now we're going to dig into a little bit of the data supporting angio-derived FFR. Just as background, Bruce reminded you about the FAME2 trial. This was a study of patients with stable single or multivessel coronary disease who were randomized if they had at least one stenosis with an abnormal wire-based FFR to either PCI plus medical therapy or medical therapy alone with a primary endpoint of death, MI, and urgent revascularization at 2 years. And the reason I show you this is because the 5-year follow-up were just published, and one point that I wanted to highlight was that this was the first time really in stable patients that PCI was shown to reduce myocardial infarction, as shown here at 5 years compared with medical therapy alone in patients with stable disease. We also have some other data. This is a meta-analysis of 2,400 patients with stable coronary disease from 3 randomized trials that showed FFR-guided PCI compared with medical therapy alone reduced death and MI. So hard endpoints. And then these are some data that haven't been published yet and that you haven't seen. This is a study that one of our fellows, Rushi Parikh, has just finished, looking at almost 18,000 patients undergoing PCI at 66 VA hospitals in the United States, and showing that those who had FFR-guided procedures had lower all-cause mortality at 1 year compared to angio-guided. So these studies demonstrate that FFR-guided PCI improves hard outcomes, death and MI, in patients with stable CAD when compared with medical therapy alone. Yet, as you heard from Bruce, and I'm sure you're aware, wire-based coronary physiologic lesion assessment remains underutilized worldwide. And so why don't we perform FFR? Well, to be honest, in the United States, some of it is driven by financial concerns or implications. You know, you get paid for putting in stents, and whether it's conscious or subconscious, I think some people, use that to guide their decisions. It does take time. There are definitely wire handling issues that we're all aware of. The pressure drift can be frustrating when you pull the wire back and find out that the pressures are no longer equalized. Adenosine, using it, getting the nurses to mix it properly, getting it to run properly and so forth, and side effects. And it's expensive, and there is a small risk to putting a wire down a vessel. And when you look at all these, you see that the coronary pressure wire and adenosine are really key factors in most of the reasons why people don't do FFR. And so that's what I think is so exciting about the angio-derived FFR, is that it can be done without a pressure wire and without adenosine, and just based on your standard coronary angiogram. You heard a little bit about how FFRangio works and is done, and now what I'd like to do is talk a little bit about some of the data. We just finished about a year ago now the FAST FFR trial. This was a study with the rationale of validating FFRangio when performed on-site by independent local operators who were blinded to the pressure wire-derived FFR, and then compared with core laboratory analyzed FFR values in a large prospective multi-center fashion. So the way it worked, I'll show you, is that an angiogram would be performed, and if the patient had a lesion that was suspicious, the images would be sent to a separate room in the cath lab where a blinded operator would perform the FFRangio. And then the operator in the cath lab would go ahead and measure invasive FFR blinded to the FFRangio. And then both of those measurements were sent to 2 different core labs who were blinded to each other. So this was completely controlled, so people did not know what was going on. This is an example of one of the cases we had where the wire-based was 0.68 and the FFRangio was 0.69. This was another case that we had a little less significant looking proximal LAD. The wire-based was 0.87 and the FFRangio was 0.90. So in this study, there were 10 centers throughout the US and Europe. 301 patients were included. The average age was patients in their mid-60s. There was 75% or so were men. Typical risk factors, about a third were diabetic. You see that about 40% of patients were presenting with acute coronary syndromes. STEMI was not included in this trial. As far as the lesion characteristics, about half of the lesions were in the LAD. You see that the average diameter stenosis was 63%. And there was a fair amount of what you might consider complex lesions, bifurcation or tortuous or calcified, as shown below. So as far as the wire-based FFR results, the mean value was 0.81 and 43% were positive. And between sort of the zone where we most commonly measure FFR, 0.70 to 0.90, or 60%, and 30% were right around the gray zone. So this was a very representative population of lesions that are typically interrogated with wire-based FFR. When you look at FFRangio, the values were very similar. The mean was 0.80. Again, about 45% were positive, and a third fell in that zone between 0.75 and 0.85. And it was successfully performed. FFRangio was in almost all cases, 99%. So there were two co-primary endpoints in this study, the sensitivity and the specificity, and they were 93.5 and 91.2%, which were both well above the pre-specified cutoff points. The diagnostic accuracy was 92%. When you just focus on lesions around the cut point, the accuracy was still excellent at 87%. Any test right at its cut point will have an accuracy of 50%. So the fact that this in this zone was 87% was a very reassuring finding. Now, of course, there were a few cases that were discordant. You see here the 24 discordant cases, and it's interesting to look at these to see if there are any predictors of discordance. And when we look at clinical characteristics, particularly things like BMI, they were not significantly predictive. In fact, patients with lower BMI had, if anything, a trend, but that didn't meet statistical significance, so it was probably just the play of chance. When we look at lesion or vessel characteristics, there was one thing that showed up in this study, in that right coronary lesions tended to be have a higher preponderance of being discordant. Now, we're not sure what to make of that, and when a larger pooled analysis was performed of 700 lesions from 5 studies comparing FFRangio to FFR, you see that still very good diagnostic accuracy of 92%. And the accuracy, this should read FFRangio, in the right coronary lesions was 89%, and it was not significantly different from other lesions. So when we broadened it to a larger population, that finding dropped out. A sub-study that Niels Johnson performed asked the question of which correlates better with wire-based FFR, a non-hyperemic pressure ratio like IFR, or FFRangio. And what he found was that IFR or DPR, another one of the non-hyperemic pressure ratios, had about an 83% accuracy. Just plain old resting PDPA had an 85% accuracy, and FFRangio 92.4%. So the implications of this sub-study are that these findings suggest that centers wishing to avoid FFR for whatever logistical or clinical reasons would be better served by just abandoning invasive pressure wires completely and instead employing a non-invasive FFR derived from the angiogram. I'd like to also show a real-world case. We are also using the program commercially at Stanford. This is a 77-year-old man with hypertension and dyslipidemia. He presented to his local physician with progressive exertional chest discomfort. He had had a coronary calcium scan about 6 months prior that had showed a very high calcium score in the 90th percentile. And so his physician was concerned and did a myocardial perfusion scan, and this showed no ischemia. And because of his symptoms and the high calcium score and his risk factors and so forth, he was referred for coronary angiography. And what you'll see here is, again, kind of similar to Bruce's case, a sort of modest mid-LAD lesion that isn't overly eye-catching, but is somewhat concerning, and then a more focal lesion in the circumflex. And I'd say, 15 or 20 years ago, Many operators would just stent that OM and treat the LAD medically and then, move on to their next case. So in this case, the OM FFR angio was 0.89, so well above the ischemic cutoff. And we too were early in our experience, so we're confirming things to reassure ourselves, and the wire-based FFR was 0.94. And then in that LAD, it was 0.75, which was a little surprising, to be honest. But we were even more surprised when we saw that the wire-based FFR was 0.64. So this, again, physiologic guidance clearly pointed us in the right direction and identified the significant disease, and so the LAD was treated. And this brings up the role of FFRangio in patients with multi-vessel disease. This study was just published of 50 patients with 2 or 3 vessel disease that had FFR and FFRangio measured, and also showed a very high sensitivity, specificity, and diagnostic accuracy of 92%. FFRangio was also significantly faster than FFR, 9 minutes versus about 15 minutes, which I think in multi-vessel disease is particularly relevant. So in conclusion, there are a number of recent studies that demonstrate the clinical benefit of FFR-guided PCI in patients with stable coronary disease. Wire-based FFR remains underutilized. FFRangio was found to have an excellent correlation with FFR in the FAST FFR trial, as well as other real-world studies. I think FFRangio should increase the adoption of physiology-guided revascularization and hopefully improve patient outcomes. Thanks for your attention.